speaker for today. She is no other than Dr. Anita Kemi Dasilva-ibru. She's a consultant, gynecologist, and obstetrician, and the founder of Women at Risk International Foundation that is doing so much work in this area. I'm really excited and we're really honored to have her speak on this topic. Her special interests include obstetrics and gynecology, gender-based violence, public health, and policy. Dr. Kemi, welcome to the call. We're going to stop sharing now so that you can share your slides.
Thank you very much for having me, Kendra. I'll go ahead and share my slides so we can begin.
If you could speak louder so that we can hear you better.
Okay. How's that? Is that better?
Yes, it is.
So, as I said, thank you very much for having me. As you mentioned, my background is in obstetrics and gynecology, but it extends to public health. And in addition to my active practice, I also run a non-profit organization, the Women at Risk International Foundation, that addresses the prevalence of rape, sexual violence, and trafficking of young girls and women across communities in Nigeria. So today I'm here to share a bit of information with regards to the screening and caring of a woman who has experienced a sexual encounter or sexual assault. The topics that we will be covering today would be the terminology, which sometimes gets a little confusing, our prevalence, which Kendra, you'd mentioned briefly in the context of COVID-19, what happens when you visit a rape crisis center. I'm using the Warif Rape Crisis Center as a prototype for this discussion, but generally most rape crisis centers traditionally follow the same procedures. And then finally, I'll have a few words to say about the follow-up of these cases. So with regard to the terminology, a lot of times we discuss gender-based violence, and we always refer to the survivor as a she, because many a times gender-based violence is interchangeable when you discuss the violence against women and girls. But traditionally, gender-based violence is really violence against any individual based on that identity, whether it's biological or whether it's preferred. And gender-based violence can be physical.
I'm so sorry to butt in, but if you could please put your slide in presentation mode so that it's bolder for people to see at the bottom of the screen. The one just before. No, not that. The one just before the minus sign for the volume.
How are we doing?
Yes, thank you. Perfect.
Okay. So we were at the point where we were discussing terminology, and I had mentioned that gender-based violence, in spite of the fact that it's interchangeable with regards to violence against women, it is actually any individual based on his or her gender identity or biological sex. And it could be physical, it could be sexual, it could be verbal, or it could actually be psychologically based. When we discuss sexual assaults, however, this is now sexual contact or a behavior that could occur without an explicit consent. And it could range from fondling, from unwanted sexual acts that could be oral, or it could be penetrative. And in that definition, we now refer to this as rape. So rape is actually the most pervasive form of a sexual assault. And this is actually an anus or mouth of another individual with the use of a body part or an inanimate object without consent. Now that I have, Kendra, now that you've asked me to move into this presentation, I can't move my slides, Kendra.
So can we try, with the downward button? Is it
It's
working
not
now?
working. No.
Okay.
Okay.
Do you want us to share it for you?
Oh, here we go. Figure that
okay,
one out.
great. Great. Okay.
Okay. So with regards to the prevalence, now based on a UNICEF report in 2014, we're aware that in Nigeria today, 1 in 4 girls would report or experience at least one violent sexual encounter before the age of 18. We also know, based on the same report, that 1 in 10 boys would also have experienced at least one violent sexual encounter before the same age. It was noted that 70.5% of the girls would experience more than one, and 69.2% of the boys would also have experienced more than one incident. Of those that were in the sample group, only 5% of the children requested or tried to access medical services, and only 3.5% actually received any assistance. When you visit a rape crisis center or a sexual assault referral center, the very first thing that you're looking for is care and assistance. You're looking for a safe haven. You're looking for a non-judgmental place where all of your services and all of your challenges can be met. At the Warrior Center, it was very important for us to provide a survivor-centered approach in addressing the needs of a woman who unfortunately has experienced a sexual encounter. So we look at not just her medical needs, we look at her psychosocial needs, and we also look at her social welfare needs. The traditional definition of a rape crisis center is more of an acute facility, and immediate attention is met with regards to the medical and sometimes the psychosocial needs of the woman. But in Nigeria, being cognizant of the fact that we're not necessarily a welfare country, and many women sadly don't have access to a lot of their social welfare needs, this was an area that we had to expand and include in the services that we provide. So therefore, we have a center that provides, in addition to acute services, we also provide long-term services to these women. Because we're working in an environment that referrals are not necessarily immediate, and because we appreciate that women that are seen need to be followed up, we also offer 2 additional follow-up services, during the course of which we will then establish whether or not additional services can be met on a referral basis. All the services that we offer at the Warrior Center are free. When a woman walks into the Warrior Center, as with many, and I'm assuming I'm speaking to majority of the healthcare workers and professionals, we all appreciate that the very first thing we want to establish is the history taking. We want to establish the narrative. The very first thing that we do is we adopt the approach of asking the 5 W's. The first is the who. We want to find out who the perpetrator is, if the perpetrator is well known to the survivor. We want to find out the what type of assault occurred. Was it oral? Was it vaginal? Was it with physical violence? Was a condom use? And was there any ejaculate? We want to find out where. Was it in her home? Was it indoors? Was it outdoors? We want to find out the when, because we need to be able to establish the period of time between when the attack occurred and when we see her, especially when it comes to the type of medical examination that we can offer her, and of course the treatment protocol that we can offer her as well. Then we want to go into some more specific history. This is where we now ask about her previous medical history and her previous surgical history. Under her OBGYN history, we want to establish whether she started to have a menstrual flow. Sadly, we also see children as well as young girls. The youngest that we've seen at the Warrior Center is only age 2, and the oldest is over the age of 70. And so we're dealing with 2 extremes where menstrual history is relevant. We're also interested in her previous sexual experiences. Are we dealing with a girl that has sadly never encountered any sexual experiences prior to this horrific event? We want to know whether she's on any medication, pre-existing medical conditions have led to the use of any medication. And we want to establish her mental health history, whether we're dealing with a woman that already has mental health challenges that we need to be made aware of. A couple of things to bear in mind when you're taking a history. If a woman does not necessarily want to disclose who the perpetrator is, that's fine. It's okay, and there's no need to force the issue, and there's no need to make her feel uncomfortable. And then with regards to the assault, a woman may not necessarily feel like telling you in great detail how the assault occurred. And if she does not, then you either try to find the right words to ask these questions, or you leave well alone. Try to use familiar terminology. As medical practitioners, we sometimes revert back into our medical speak and our medical language. And so sometimes it might be difficult for her to understand what the questions that are asked of her. So perhaps, instead of using, words that might not be familiar with her or to her, it might be more comfortable if you find somebody that speaks her language, for instance. And then perhaps you can share the story in her native tongue, which is a more familiar way of sharing and explaining the act that occurred. Sometimes there's memory loss, and that's okay too. She may not necessarily remember when it happened, how it happened. And if that's a situation that you find yourself in, then that's the way things have to be. Sometimes she might need timeouts because it gets very emotional. So you can't rush through a history taking. You have to, read the room, as it were, read her body language. And that's the next thing, the body language. The body language is very important. But it's not enough just to read her body language. You need to be very mindful of yours. You can't shy away or be visibly disgusted while she's telling her story. You need to be attentive, but you also need to be very much aware of the fact that she is also watching you to seek validation from your responses. And so when you're taking a history, you need to obviously be mindful of this fact as well. When it comes to the next aspect of the services offered, this is now the forensic or medical examination. We spoke about the timing, the period between when the attack occurred and when we see survivors at the center. For us to be able to carry out a forensic medical examination, we would need a period of a maximum of 72 hours. Unfortunately, after 72 hours, certain specimens that you're trying to retrieve become biodegradable and are no longer being able to use when sent to the DNA lab. The very first thing you do is a top to toe. You examine her from head to toe. You examine her cuts, you examine her bruises, you examine any areas that may appear swollen, and you generally take your time. When it comes to the genital examination or the genitoanal examination, you have to be very mindful of the fact that this is a traumatic event, and so therefore care has to be taken. You have to seek her permission. You have to wait to see whether or not she's willing. And if she is not willing at that point in time, you have to make time for her to arrive at that place with you. And then of course, it's very important to accurately document all the injuries that you see and using a body chart, which I'll show you in a minute. Couple of tips that I've also touched upon when you're examining. As we mentioned, consent is important. You cannot examine a woman without her consent. It's important for you to have a chaperone in the room, especially if you're a male examiner, but even if you are a female examiner, it's advisable that you always have a chaperone in the room when you examine. I mentioned the use of a body chart, which looks something like this. And this is where it's easy for you to mark off areas that you have identified injuries so that you can then refer to them, both because, for example, at the Worry Center, because we are official members of the Lagos State Domestic and Sexual Violence Response Team, our medical reports are actually legal documents. And these are reports that can be used in the judicial system if a woman chooses to actually seek justice and take her perpetrator to court. Other tips in collecting forensic samples: try not to reduce repeating procedures. For example, if it's an examination of the vaginal vault with the use of a speculum, please try and do this only once. Ensure that you have all your necessary vaginal swabs taken so that you do not this process. And of course, this would be of further distress to your survivors. As important as the positive findings is also the negative findings. If, for instance, you examined a woman and there are no injuries, it's important to take note of that fact and mention that there were no injuries documented at that point. Aftercare, after you have examined her, it's important to make sure that she is in a good place. It's important to afford her the dignity and the respect of giving her time to process what you've done, allow her to get dressed, ask her if she's in need of any other additional assistance. And then, as I mentioned earlier, because this is a legal document, if there is need to communicate with the police, please go ahead and ensure that these reports are documented, the process that is involved in transferring the report from your center to the police is not broken or contaminated in any way. Once you've examined a patient and once you've established that you've documented all the necessary injuries and findings, the next thing that you would then concern yourself with would be the administration of the drugs. Based on her history and the fact that you've now established when the attack occurred, you are now likely to consider administering either an emergency contraceptive pill, if indeed the attack was within a 5-day window. Traditionally, I know that when it comes to an emergency pill, we tend to say to most of our patients, especially if I were to put my OBGYN hat on, that it's best that you take the pill within a 3-day period. However, with light of these cases from a sexual assault referral center viewpoint and the forensics that we carry out, it's been advised that we can continue up until 5 days. With regards to the prophylactic antibiotics, again, it will depend on her history and your physical findings. If, for example, on your vaginal examination, it is evident that there's a vaginal discharge, if there's a suspicion that an infection might be present, then the consideration of an antibiotic would be given. If it's clear that there was no penetrative sexual intercourse in the course of the attack, then at that point, perhaps you may not consider giving a prophylactic antibiotic. The administration of post-exposure prophylactic HIV drugs is also another important point that we need to discuss. Again, based on the fact that you're now aware of when the duration between the attack and when you see her has been established, if this is within a 72-hour window, you can go ahead and offer her the PEP drugs. This is a tablet taken daily over the course of 28 days. The lab investigations that one typically carries out, you would want to screen for sexually transmitted diseases. So you would want to carry out an HIV test. You want to carry out a hepatitis B. You might want to do a C. You'd want to carry out a syphilis test, which is your VDRL. And then, of course, you'd carry out a beta HCG, which is your pregnancy test. Once you've carried out all of the tests, once you've carried out the physical examination and you've established whether or not administration of drugs has been given, the next thing you want to establish is her emotional state. The counseling session is just as important as the physical examination and treatment that you've just implemented. When you counsel, you have to remember that this is a confidential dialogue between yourself and your client. And essentially what you're doing is you're trying to assist her in coping with the stress and helping her make the decisions that she needs to following this attack. You want to help her find closure. You want to give her some coping mechanisms and skills that she would need during this very difficult time. You want to help her or him understand what's been going on, why it's happening. And then you also want to apply some sort of behavioral therapy or cognitive therapy, and this is under the purview of a counselor and the specialties that the counselor has to be able to help this young person in dealing with this awful event. There are different types of counseling sessions that we offer at the Warwick Center. We have our trauma counseling for active cases that we see. individual counseling sessions that are offered. We also have, like I mentioned, the follow-up individual counseling sessions that we offer to all our survivors. We, in addition to that, offer group counseling sessions. These are both physical counseling sessions, and presently with the COVID-19, we've started offering weekly virtual counseling sessions that have actually become rather popular over the last few weeks. The Warrior Center also have a 24-hour confidential helpline. These are helplines that are actively manned by counselors. And so you could start a counseling session on the phone, especially for women that are either reluctant to visit the Warrior Center because of the shame that usually accompanies these types of abuse, or she's just geographically too far away to visit. There are different effects a sexual assault can have on a survivor. The physical signs that you immediately start to see would be the bruising, the laceration. You could see some bleeding, whether it's anal or vaginal, depending on if a penetrative act was perpetrated upon her or him. You could notice physical abuse, so you could see signs like broken bones and other injuries. And then you could see signs of a sexually transmitted disease, like I mentioned, whether it's a vaginal discharge or discoloration over the vaginal area. And then finally, if you see her after the attack has occurred, over the period of, say, the first 3 months, you might even start to discuss signs of pregnancy, because she may start to tell you information such as she hasn't had a period. And of course, by then, a pregnancy test may have revealed that, indeed she is pregnant. Emotionally, a survivor would immediately stop trusting people around her. The narrative will tell you that traditionally, perpetrators are well known to survivors. These are usually family members or friends. They could be a father figure, whether biological or otherwise. And it usually happens in places that are considered safe havens for survivors. It could happen at home or in a school or even in a church. A lot of survivors deal with a lot of anger issues. Why me? Many of them could lose control. Many of them lash out. There's a lot of feeling of lack of self-worth when it comes to having dealt with sexual assaults. There's a sense of vulnerability because you were once upon a time invincible, but somebody has come into your space, overpowered you, both physically and emotionally, and taken away your power. There's fear. You're constantly afraid. You're looking around. You're worried whether this would happen again. And then, of course, we're living in an environment where victim blaming is common. And so a lot of times, unfortunately, survivors are made to feel guilty. They're made to blame themselves. They're actually questioned. They're sometimes even verbally blamed and outspokenly blamed as to why it happened to them and not to somebody else. There are behavioral changes that you may notice. You may notice that a survivor starts to become a lot more withdrawn, changes of habit, certain things that were once enjoyable are no longer. Chronic fatigue, they are always tired. Sometimes they undergo these involuntary shaking episodes. There's a change in eating and sleeping habits. Some of them suffer from insomniac attacks. They cannot sleep. Many of them start having eating disorders because that is the only way that they can get a sense of control, by being able to control whether they can or cannot eat. So we sometimes start to see disorders such as anorexia or bulimia. There's also a sexual dysfunction, a lack of interest in sexual relations. And in some instances, especially with the younger survivors, there could be self-harming behavioral changes, because again, that's the means of control. Psychologically, post-traumatic stress disorder is seen. This could include periods of shock, flashbacks. We can have triggers that tend to remind the survivor of the event. It could be a smell, it could be a song, it could be a time of the day. Survivors sometimes in their sleep suffer from night terrors and nightmares. Many of them have severe anxiety. Periods of depression is common, the feeling of hopelessness. Many of them undergo long spells that are unexplained, crying. We mentioned the weight loss and the weight gain because of the lack of appetite or the control of their eating habits. Many have suicidal ideations. Perhaps, it might be better off if I'm dead. And some of them actually spend a lot of time trying to understand and figure out how they're going to do it. Some go through periods of dissociation. They can't focus, they're distracted, they're forgetful. This leads to a drop in dealing with students. It leads to lots of work days if we're dealing with a young woman that's at work. And essentially, these are women, young girls and women and men and young boys that are in this period for a considerably long period of time. And there is no right or wrong time for them to snap out of it. It's a period that whatever it takes and how long it takes, as a counselor, you work through it with them. Counseling skills that counselors clearly bring to the table is to actively listen. Actively listening means you don't interrupt, you don't suggest, you don't get physically and visibly upset. You allow a person to tell their story, how they tell it, when they tell it, the duration it takes to tell it is entirely up to them. You're not asked to find solutions to their problems at that point in time. You're just asked to give her the space to listen actively and believe her or him. You need to be empathetic. In other words, you cannot be sympathetic and then take on the terror, the trauma, and the guilt of her activities. You need to be empathetic and put yourself in his or her position so that you can then administer assistance as best as you can. Attentive skills that counselors clearly find useful is maintaining eye contact. Of course, we mentioned the body language, which is also important. Your questioning skills, you need to have open-ended questions. Do not give leading questions, which sometimes we do. We need to allow, again, the survivor to tell the story in her own way and in her own time. And then essentially you show her that you believe her. You just keep reassuring her and you remind her that she's certainly not to blame. The things you do not do in counseling, and we've discussed a few of them, you certainly don't argue with your client. You certainly don't say to your survivor, you should have done it this way and maybe it would have been better and you now must go to the police station. You do not give advice or you do not judge. You just actively listen quietly. You don't impose your own belief system on the survivor. Just because you believe at this point in time, because perhaps you're a spiritual person, now is the time to go and unburden to your pastor is perhaps not her belief system. And so that's not a recommended advice that you would give her at that point in time. You don't minimize her problem. You don't tell her, oh, but he only touched your breast. There are other people I see that are visibly upset because they underwent rape. You certainly don't interrupt her or him unnecessarily, and you don't block a strong emotion. If your survivor or client wants to lash out, it's okay, let them vent. As we mentioned, when you're sympathizing, you certainly do not get into that person's emotional space and become involved in their problems. You actually empathize by putting yourself in that position. And then you don't take responsibility for the client's problems and decision. You don't then at that point in time decide that you're going to go into their home and you're going to change their routine and you're going to tell them exactly what they need at that point in time. Following on from the counseling that's offered at the Warrior Center, I did touch on the fact that we also offer social welfare. And the reason being because sadly, social welfare is an aspect that adversely impacts on majority of the cases that we see. And unfortunately, these aren't services that are readily available. So we partner and we collaborate with existing organizations that can offer these services. And then we serve as a referral center so that the transition is smooth. We can have a young girl come into our center. We would immediately establish that perhaps shelter is an aspect that she's in need of. We can put in our phone calls to our partners and we can move her from the Warrior Center directly to the shelter without her having to go back home if home is the place of risk. With regards to the legal aid, being members of the Lagos State Domestic and Sexual Violence Response Team, we offer services through the Office of the Public Defender in Lagos State. We also work with organizations like FIDA and also private law firms that are happy to offer pro bono services. The vocational skills, we actually hold fairs. The last fair was for 200 young women. Reason being that sadly in our environment, women make poor choices because they're financially constrained. And so the idea behind offering vocational skills is if we're able to empower women, both financially and socially, then we hope that she's decisions the next time that she's called upon to decide whether or not to stay with her abuser. Following on from seeing her, talking to her, examining her, running our necessary tests, administering the drugs, counseling her, and then addressing her social welfare, we then advise her on follow-up visits. And the follow-up visits will be based on the findings that we have. Perhaps there might be a case that we need to see her sooner, and there are other instances where she seems to be in a good place, and then we can see her, in a longer period of time. In between the visits, we maintain contact via phone calls to monitor her well-being. And as I'd mentioned previously, we invite her back thereafter for either monthly physical group therapy sessions, and then more recently, the virtual group therapy sessions that we're offering to survivors on a weekly basis. So this brings me to the end of my presentation, and at this point in time, I think I will hand this back to Kendra and wait for any questions. Thank you very much.
Thank you so much. I mean, this was really well done. Thank you for your presentation. You touched, like all the different aspects. We had a couple of people join in, when you were, you had gone a lot into your presentation. And so my question, just as we wait for people to chat in their questions or raise their hands for questions, if you could just do like a high level summary so that those who joined late, if you could just in 2-3 minutes, just what are the key things that you have found most useful that these women need when they come to us as healthcare workers?
When women come to us as healthcare workers, they're coming to you as an expert. They're coming to you because they're seeking some sort of service. And so it's incumbent upon us to be sure that we're available to provide that service. When they come into centers like the Warrior Center and other sexual assault referral centers, their fear and concerns are multiple. So we need to address all these different concerns they have. It's very important to adopt a survivor-centered approach to what you're offering them. You need to appreciate that you have to look at the physical challenges and the medical intervention they would need at that point in time. We mentioned the counseling to address their emotional needs. You need to look at their social welfare and address that as well. And then it's important to follow through. It's not enough just to identify that there is a concern, but then you can't leave her at that point. You need to now assist her to that next level. Case in point, we had the other day a young lady that came in. We ran HIV tests on her, and she was HIV positive. So this is a woman that prior to seeing us was totally unaware of her HIV status. Now, fortunately, because we partnered with NIMA, the National Institute of Medical Research, we could then again refer her to this other agency to continue her care. In other words, we then prevented her from having to go through that trauma of starting the process right at the beginning because she's now being seen in another facility. So I think the most important thing is to remember that if you're going to address this and address this young woman, it should be a fully holistic and a survivor-centered approach that should be taken.
Okay, and so we have a comment from Dr. Coley, who is leading the RICOM 3 project and is from JPIGO, one of the partners in the RICOM 3 project. And she says the interface with law enforcement agencies, such as the police, remains a big problem for health providers and survivors. The police is yet to have the right training. And we're opening this up to the rest of, the healthcare workers we have on the team. Just as Dr. Kemi shares her own experience, we'd like you to chat in if you want to share your experience. Have you seen clients like these clients we're talking about, and what has your experience been in the transition to the police and your interaction with the client? So Dr. Kemi, in your experience at the Warrior Center, how has the interface with the police been?
So in my experience, as I earlier mentioned, one of the pillars that we work under the Warrior Center is a health pillar, but we also address a community service pillar. And in the community what we have a police training program at the WARIF organization.
I'm sorry, Dr. Kemi, but we lost you for a second. So if you could please repeat what you just said. The internet went in and out. Yes.
I just mentioned that, as I earlier highlighted, at the WARIF organization, we work under 3 specific pillars: the health, education, and community service pillar. The WARIF Center actually falls under our health pillar, but under our community service pillar, we implement measured and impactful programs to address issues like the question that was asked. So one of the programs we've implemented is a police sensitization training program, where we recognize that there are challenges when it comes to the police, there are challenges when it comes to dealing with rape survivors, and there are challenges when it comes to police understanding why the referral processes are so important. So as opposed to locking heads with the police, we decided, why don't we just educate you? Why don't we just highlight you as to why these processes are important? So to date, we've been able to train almost 800 police officers across Lagos State. And I must say that we're actually seeing a higher percentage of referrals, and we're actually having a better understanding with the police force. We're nowhere near where we should be, and definitely this is a work in progress. But again, I believe that accountability is as important as the treatment and protection of young girls and women. And the only way we can address the accountability is working with our law enforcement.